I had to change the topic of my presentation because the only patient who had combined liver and kidney failure and was listed for combined transplantation developed at week 8 of treatment. I was diagnosed having bronchial carcinoma and was stopped both on the transplant list and on treatment. He became a sustained responder and died of his lung cancer, unfortunately. So we have a large experience in treating these patients. So I took my patient number 1, who was a patient after 2 kidney transplants and had cirrhosis and was basically referred for liver transplantation. This is a male patient who received his first kidney transplant due to chronic pyelonephritis in 1992. This graft failed in 1997. So in 1998 he got a second graft, but he developed a renal cell carcinoma in the graft, and the graft was removed, and he was put on hemodialysis, so really a very difficult case. In 2004 he developed a myocardial infarction with heart failure, which fortunately recovered after receiving coronary stenting. In 2007, surprisingly late, the diagnosis of hepatitis C was made when he was re-evaluated for the 3rd kidney transplant. And he received a kidney transplant in November 2008, that was the 3rd one, and did quite well after that. But in 2011, he was referred because of ascites. A fibroscan performed was 23 kilopascal, showing a clear-cut cirrhosis. He needed repeated paracentesis, and in 2014, almost every second week. It's a very strange story, then we will see. In 2014, he had even a spontaneous bacterial peritonitis. Then he was referred for transplant evaluation, and the transplant team basically accepted the patient, providing he receives antiviral therapy. This was in March 2014, so very early on when we had this drug, so maybe today they would do it differently. What did we have in March 2014? Obviously we had PEG-RIBA. We had the combination of sof-RIBA, the combination of all 3 of them, and to try to get a second DAA by phoning drug companies to provide the drug to us. So our choice was obviously not PEG-containing regimes, which is not suggested to be a good treatment for patients after kidney transplantation, and clear-cut guidelines from the keto clearly says one should avoid pegylated interferon. Ribavirin, we will see his values. He had already impaired liver function, was not a good choice. So I was able to obtain the Clatosphere for this patient. This was his laboratory at the start of antiviral treatment, mild increases of ALT and AST. The creatinine was 3.5 with a GFR of 80 milligram per minute. Hemoglobin was normal, but it's quite surprising for this kidney patient. The platelet count was decreased. He had combined genotype 1b and 3a with a viral load of 500,000 international units per ml. So we started with 400 milligrams of sofosbuvir and 600 milligrams of Clatosphere for 24 weeks in a named patient program, and the patient got an SVR 24. Now, I'm showing this case because of the possible side effects. So this patient came after 2 weeks. Everybody was afraid because his ECG changed and he showed an intermittent right bundle block. So our response was to reduce SOF to just 200 milligram every other day. But 4 weeks later, when his cardiac problems subsided, we returned to the full dose of 400 milligram per day and maintained this dose until end of treatment. There were no further problems of treatment, but repeated paracentesis was required. I have to tell you that looking up the ascites fluid, this was a Keeler's ascites, or milky white ascites, so it was not a typical cirrhotic ascites. This is his kidney function over time. See here the treatment here. Oh, sorry. So you see here the treatment, which started at improved at the beginning of the treatment. It stabilized around 3.5 milligrams over the 4 weeks. At the end of treatment, there was an increase to almost 4 milligram per deciliter with a creatinine clearance below 10. After stopping treatment, the kidney function remained in the same range. So the follow-up now was done last time a month ago. He had reached 72 weeks of SVR, so the Hep C is gone, there's no question. He still has his ascites, still requires 2 times per month paracentesis for his Achilles ascites. His liver function is normal, his bilirubin is normal, his renal function is stable at a very low level. He doesn't require hemodialysis. And because of that, he was not transplanted. Just melt purgatory again. So you see, first I showed you the case because it clearly shows that sofosbuvir posed no problem. And I just put together all available data. I was not able to get to Liver International last week to see the last study, which was put online end of February. So I just have the other studies. And what you see here, what has been used in patients with impaired renal function with sofosbuvir containing regimes. Most of them used either cimeprevir, like the Nazario trial observation, soft with ribavirin, a very few patients with daclatasvir. This is our study, Beinhardt, which was recently accepted for publication. We had 13 patients. We have a few patients with ledipasvir, mostly in this group from Kamar, and some other treatments. And what you can basically see, that the response rate was 95% SVR rate. So these are my final slide. These are our own data, which were just accepted at Transplant International. We have treated a variety of patients with soft-containing regimes, a total of 25 patients, and we had only 1 patient who failed, so we had a response rate of 96%. You see here all patients, 1 relapse out of 25 patients. 10 patients were on dialysis, including the one who relapsed. 8 patients were post-kidney transplantation and tolerated the treatment extremely well without any problems. And 7 patients had both a kidney and a liver graft and also tolerated the treatment very well. So this was the case, just to show you that sofosbuvir is basically an acceptable treatment. I know it's in the label. Fortunately, in Austria, we have less lawyers than in the United States. The risk for the physician is lower.